Assalamu alaikum. Thank you so much for the kind invitation to this great meeting and great crowd, and thanks for the chairpersons. I'm not going to waste your time with my boring speech, but I think it's a great opportunity to talk a little bit about achalasia and how do we POEM those patients, and then they must have some sort of condition that we have to treat. Now, I'm not going to waste time on the basics, but this is shown on the pictures. That how do we diagnose achalasia from the start? We do endoscopic evaluation to make sure like we are not having pseudoachalasia and to make the peristalsis absent with tight sphincter. Manometry and to some extent barium study is actually another confirmatory test. Now, we have different sorts of achalasia treatments, including non-surgical and surgical. Till the recent years, we have been having some medications given like calcium channel blockers, maybe injections, botulinum toxins, and pneumatic balloon dilation. The surgical include the hilar myotomy, and recently we have found that actually we're treating these patients with POEM, which is per oral endoscopic myotomy. And this is a case that we did a few years ago, actually showing the classic steps of doing POEM procedure. The most left slide basically showing the aperistaltic esophagus with dilated lumen, and then submucosal incision followed by tunneling and myotomy, and ending up with closure using clips. Now, those patients, when they have lower esophageal sphincter pressure relieved after POEM, they are exposed to reflux, and that reflux will increase the chances of forming paresophagus as well as the use of PPI therapy, which can lead to osteoporosis, osteopenia, bone fractures, as well as kidney, liver, and multi-organ diseases, as some of the textbooks are mentioning and referring. And so what about the incidence of acid reflux post-POEM? Now, there was a study looking at 600 patients received POEM between the 2009 and 2019. Mostly were of type 2 achalasia. 400 of each, which was about 60%, were positive. That was positive pH study. An endoscopy was actually done afterwards, showing about 50% of those patients had some changes consistent with reflux esophagitis. Now, the study provides several noteworthy and reassuring facts, including that most of those patients actually have GERD, asymptomatic, and most of these are actually infrequent symptoms, and they respond well to PPI therapy. Now, these are the changes seen, in case if you don't know them, on endoscopic evaluation, which we call the LA grading scoring system for esophagitis, starting with less than 5 millimeter length, more than 5 millimeter length, and then 70% or even more. Now, what about the risk factors to develop GERD after treatment of POEM? Now, another study looked at randomized trials and basically evaluated GERD in post-POEM patients using 3 methods, including pH, capsule, endoscopic findings, and even symptoms. For each patient, the analysis involved full thickness versus circular myotomy, anterior versus posterior approach, long versus short myotomy, and naive versus previous therapy patients, and different types of achalasia 1, 2, 3, through 3. Now, that study included over than 2,500 patients, identified 25 studies with inclusion criteria. 18 were included in the meta-analysis. According to endoscopic findings, circular and anterior myotomy demonstrated a lowest trend to develop GERD. In pH monitoring and symptoms analysis, circular myotomy, anterior myotomy, treatment naive, and non-hilar myotomy patients were associated with the lowest recurrence rates. Now, that concludes circular approach, and anterior approach actually among the least to develop GERD post-POEM. Now, how about endoscopic anti-reflux or endoscopic fundoplication to prevent post-POEM patients? Now, transoral incisionless fundoplication, also known as TIF, is a novel therapeutic endoscopic technique for the management of patients with GERD, not only exclusive to POEM, but even the GERD patients. involves creation of 270 to 330 degree full thickness esophagogastric fundoplication via an over device called esophax. Now, patients who are status post-POEM and suffering from acid exposure are best candidates. Now, comparing TIF to laparoscopic Nissen fundoplication, they both actually reduce the hernia in case if they were less than 2 centimeter, repair hernia that are more than 2 centimeters, including CTIF. They elongate the high pressure zone. The fundoplication actually does an approximate and tighten the fundus around the distal esophagus, recreate the dynamics of angle of Hess, and restore the distal high pressure zone. And this is a patient which I did not too long ago, showing the sphincter or the angle of Hess. This is Hill grade 2, which means incompetent valve with the loss of the angle of Hess. This is the esophagus over tube being introduced within the patient. Then the scope is withdrawn, and the esophagus actually will be flipped. That includes some steps. We have to first use the helix to bring the esophagus deep into the stomach to create the esophagogastric fundoplication. With rotation made at 11 o'clock and 1 o'clock, we will be able to create the high pressure zone. The high pressure zone before the procedure was less than 1 centimeter, and after the procedure was about 4 centimeter, which is actually ideal to the Nissen fundoplication procedure done surgically. At the end, this is the 1 o'clock rotations done. A total, we fire 10 clips, which we call them serosal fix clips. And for the sake of time, I'm going to jump to the conclusion here. So as I mentioned, on the left side, actually, the valve before the recreation, and on the right side, the valve after the recreation. You can appreciate the Z line was brought down from 39 centimeter down to 43 centimeter, creating a 4 centimeter high pressure zone. And this is actually the gastrographin after the procedure, after 1 week. You could appreciate that the patient was able to swallow the barium in both positions, supine and flat, and none of which actually revealed any reflux. There's a smooth flow of the barium, so there was no high pressure interference, and this is how the patient is laying flat and the barium is trapped in the stomach. And this is actually one of the recent cases. I started doing GERDX. So people were actually criticizing me for only being a TIF guy, but now I have done about 5 cases of GERDX. The GERDX, the only thing it lacks, it does not recreate the valve. It does not do the fundoplication, but it has the same results. Patient procedure in both require no more than 60 minutes. The elongation of the valve is much less in the GERDX. GERDX, you must bring the device out to reload and bring it in back. In TIF, I don't have to do this. So both has cons and pros, but I find both of them actually very effective. So take home points. Post-POEM TIF or GERDX appears to be feasible, safe, and very efficacious to improve the symptoms and esophagitis in case if they are present, decreasing the long-term risk of acid exposure as well as risk of long-term PPI use in patients post-POEM. And patient post-POEM with symptomatic reflux should be considered for these endoscopic fundoplications. And again, you should not wait too long, and you should really carefully look for them. Now, I will take this opportunity to announce our International Gastrointestinal Cancer Congress, which will be held in March in the city of Jeddah. It will be the first multidisciplinary conference touching base on the GI cancers. And thank you so much.
Thank you, Dr. Emad, for this elegant presentation of cases of achalasia that are treated endoscopically.
احنا عايزين نعمل ديسكشن.
هنخليها بس بعد المحاضره الاخيره يا حاضر عشان الناس تلحق. حاضر. هنخلي الديسكشن بعد المحاضره الاخيره دكتور زمزم يتكلم والمناقشه موجوده واحنا موجودين.
No, this is not fair. We have to ask every speaker one question at least.
فور تايم بس يا بيه. حضرتك تحب سؤال واحد سريع تحت امر حضرتك.
No need for us to sit here. We have to do a dialogue between us and the speaker.
لو حضرتك عايز تدي سؤال واحد للسبيكر تحت امر حضرتك في الاول.
معلش انا ما ابغى اسوي مشاكل هنا. ما ابغى اسوي مشاكل. تحت امرك.
Yes, yeah, you give a very nice lecture, and you raised up a very important problem.
Yeah.
I would like to ask you about what are you doing? You are just creating structure, and the sphincter is not there. This is the point. And you know the trends now, or the most updated management, and that should be, is crural repair.
Right.
Repair of the crura. This is the main principle for proper management of GERD. And let me tell you that the magnetic ring that links is the most physiological procedure to treat GERD. But it has many complications like erosions, perforations. What do you think?
So, well, that takes longer than I intended, but just to make it simple, 20 years ago, before we invented PPIs, those patients used to suffer the complications of cancer, stricture, peptic strictures, and since we have invented PPI, we're not seeing these things anymore. However, when we say PPI is a treatment for reflux or acid reflux, it does minimize or decrease the acidity of the refluxate. However, it does not prevent the fluid from migrating down from the stomach all the way up. So those patients actually still can get pneumonitis and complications. Now, since we also brought up the Nissen fundoplication, patient used to have another option to avoid taking PPI, and that's why we're making it very conditional in case if you have complications or side effects from the PPI, or you cannot tolerate them, or you cannot afford them, or even you're not very compliant, then surgery is given as an option. Now, since we have an endoscopic fundoplication and more procedures coming, it is much easier than doing the fundoplication itself as a surgery. You know, I do manometries and I see patients post Nissen fundoplication, and one of the most common side effects and complications they suffer from is dysphagia. Sometimes the surgeon is making it a little bit tighter than it's supposed to be, and they suffer from inability to swallow to the point that they actually go back to surgery and undo the fundoplication.
Okay, what you are mentioning is very interesting.
Yes, so-
Even with doing laparoscopic fundoplication, still
Right.
there are complications. I would like to ask you, you have two types of fundoplication. You have Toupet and you have Nissen fundoplication.
Absolutely.
What you are doing endoscopically, is it Toupet
Like the
or
Toupet, yes.
Nissen?
Absolutely.
Like Toupet.
Like
You
Toupet.
see, it's incomplete wrap.
That's absolutely right.
Yeah.
And you know what? We slowly find, and I have the chance to speak to the scientific committee within the Thoracic Surgery Society, and they were thinking that doing the 360 degree is actually an overkill, and they have more dysphagia feeling. And that's why they are doing the Toupet. The TIF is actually the Toupet with much better outcomes and easier intervention in a procedure that does not take more than 15 minutes, and the patient doesn't have to stay in the hospital. And I think it's the perfect solution.
Thank you very much.
Thank you, Dr. Emad, and I have to